Okay, good morning, everyone, and thank you for attending our Grand Round lectures. Our lecture today is courtesy of the George Vetrovec Cardiology Symposium, which was founded in 2015 by faculty and friends on his retirement. This symposium goal is to have an annual lecture for the Division of Cardiology. I am pleased to introduce to you our speaker today, Catherine Biga, who is the president of ACC. Um, she's going to give us a lecture titled Top 10 Environmental Factors Impacting Cardiovascular Care Delivery in 2025. Catherine is also the president and CEO of Cardiovascular Management of Illinois, a cardiology physician practice management company. She has worked with more than 100 cardiovascular providers in Chicago area and partners in their cardiovascular service line at more than 14 acute care hospitals. She earned her bachelor's degrees in nursing from the Mayo College of St. Teresa and Master of Science in Nursing from Northern Illinois School of Nursing. She has more than 40 years of experience as a registered nurse, service line director, hospital vice president, and CEO. She also has 30-year experience in physician practice management. Nationally, she's active in consultation for strategic planning, operational efficiencies, integrated financial and quality initiative, growth and development of cardiovascular services. Her main focus is on facilitating the integration of strategic, financial, and quality perspective between cardiovascular service lines at practices and hospitals. She also consults and lectures on numerous contemporary cardiovascular topics. She is a member of ACC Board of Trustees, a past member of the American Association of Cardiovascular and Pulmonary Rehabilitation Board, and was the inaugural chair of the MedAxion Board of Managers. We are grateful for Catherine Biga's expertise on the topic above and look forward to learning from her. Please submit your question through chat function on the Zoom as they arise during the talk. At the end, as they arise during the talk. At the end of the talk, we will offer you a code to claim your credit through credit for CME and MOC. And also we will provide this number on top of your screen. For question on how to log into your Cloud CME account, visit vcu.cloud-cme.com or contact Shannon Winston. I will now turn it over to Catherine Biga to give us to talk to us about the topic of today. Ms. Biga.
Thank you so much, David, and it's an honor and a privilege to be here with you all today. I hear you're under a few challenges out there in Virginia, so I appreciate that as we all work in our day jobs. And I've worked through phone outages and obviously electrical outages. I don't think I've ever been under a boil order, though, so you guys will have to tell me how that works out in a busy clinical practice. Also want to say hi to a few of my colleagues and friends that I see out there. And we are going to talk about dyad leadership. I see one of my dyads on the phone. Chris, good morning. It's great to see you. As those of you I know should be very proud of Chris. He'll be our incoming president in just a few short weeks. I'm in my last quarter, so it's been an honor to be with Chris. We're also going to do something a little bit different this morning. And I've got the chat up, so if I'm moving my head, it's because I'm looking over at the chat. So feel free to ask questions. As most people will tell you, and those that have heard me before, I tend to talk fast. This talk in particular is chunked a little bit differently. And we're going to cover, you're all so good in your clinical competencies. This morning's going to be a little bit different as we look at those non-clinical competencies that are really going to be so important as we head into 2025 with a change that has been going on, but will actually continue to go on as we move through all of this. I don't have any disclosures for this specific topic, so we'll just dive right in. And if we don't get to the end, you certainly are more than welcome to the slides, because the way I set this up, and I had to change this entire talk, obviously, with the events that have been happening in the last 60 days. So we're going to be heavy on the top end with finances, but the core of this discussion this morning is really all about transformation of cardiovascular care. We started during COVID, and then we went right back to our comfort zone. So what we're seeing is this underlying disruption of our infrastructure. But as you'll see, especially with Virginia, you tend to be a little bit behind the rest of the country in some of these impacts. So some of this you may not see, and you'll be saying, what is she talking about? I'm going to go get another cup of coffee. But I would encourage you to listen, because I did this talk actually in Virginia when I was working with Martha Jefferson a lot of years ago. And some of the things when I put this talk together have really evolved over 5 to 6 years, especially for my fellow. So I was thrilled to see David and have him introduce me. So without further ado, these are what I consider my top 10 trends. And you'll notice the ones on the left, the 4 are where we're going to spend the majority of the time. They're sort of the problem, the issues that we're seeing. The stuff on the right is what I've done in my day job. As we mentioned, my day job was with 120 cardiologists across 14 acute care hospitals. I'm in the process of trying to semi-retire. I will miss my physicians immensely, but as all of you know that are in this on a day-to-day basis, it's getting completely and very complex. When I first wanted to start talking about the environmental trends, I thought, who's going to listen to Cathie Biga? What is she really going to say about this? And interestingly enough, I participated in a Wharton course. Wharton, as most of you know, is this little tiny business college, pretty well known. And this is what their team had put together. Now, remember, I said I talk fast, so I took 12 and reduced them to 10. But if you crosswalk each one of these that Wharton had put together for their 12 major challenges, you will see that every single one of the items that I have are embedded in here in one way, shape, form, or another. So where are we going and how do we get there? So we talk about value-based care all the time. We talk about it, we've been talking about it for years. Paul Cassell at the college has been very involved in it, works with MedPAC and a lot of our agencies in Washington. You can see what's happening with our Medicare population. I'd like to thank all of you for working. I am now officially a Medicare beneficiary. I will tell you, it's one of the best insurance policies ever. I own my own company. As many of you know, it cost me $40,000 a year for a $5,000 deductible for insurance. So when I went to Medicare, I really honestly thought I had died and gone to heaven. So it's really an amazing insurance policy. It is changing and it is evolving. We are having many people join Medicare every single year. The issue is Medicare Advantage. Medicare Advantage enrollment is now over 50% of all of Medicare. Why do you care? You're sitting there this morning knowing you've got a cath, you've got a big clinic. Why do you care that Medicare Advantage is going up? Because the administrative burden of taking care of our patients with Medicare Advantage is significantly different. So it increased our costs. So it is really important. So now take myself to Virginia, whether I'm in Charlottesville, Roanoke, wherever I am in Virginia. You're very interesting because unlike the rest of the country, now I have not seen your numbers since open enrollment. Open enrollment just ended in early December. Maybe we'll see this shift a little bit as it is shifting. We're at 66% in Illinois on Medicare Advantage. You're only at 36%. So you're still moving very slowly, which for your administrators is good. For you, it's good as you think about pre-authorization. That's usually the one that resonates with physicians when I talk about pre-authorization, because you don't have to do pre-authorization with your Medicare patients. You're also starting to see a huge shift in Medicaid with Medigap insurances and with Part D prescription plans. So when you start talking about the complexity of healthcare economics, knowing that in Virginia alone, there's 24 different Part D plans. This is why our lives are becoming so complicated and why the transformation of care becomes so difficult. So as I mentioned, 1% of our population is taking care of 21% of us that are spending your money. So when we look at Medicare, the issue that we've got, and this is where you could all help us, because the reality is 70 to 80% of healthcare dollars are spent in the last 18 months of life. Why is that? Because we continue to do a fairly poor job in helping our patients through their chronic illnesses, especially when we get towards the end of life. Palliative care, hospice care, we just are not very good at. So spending our money at the end is not our goal. We really need to make sure our patients not living longer, but living healthier. Healthy life months is what we're really looking for. And we've got to try to get this curve reduced because we can't afford it. So now I turn to my physicians. They are not responsible for the cost. So we see all of this chatter going on, make America healthy again. So we know we're going to have a lot of changes with our new administration. But this graph very clearly shows that it's not our physicians. And I could not tolerate putting the 24 graph on here or the 25 graph, because of course we know in 2025, our bill failed at the 11th hour in Washington, and the full impact of the 2.83% cut is in place for us unless it gets changed by Congress, which I'm not terribly optimistic. So value, we still keep talking about value. Well, the shot across the bow started in August of 2023 when Medicare said, okay, we're going to change. Here are our 5 drivers for Medicare. And you'll notice, luckily, they did add advancing health equity. They also knew, and we're going to talk about this in a little bit, they knew that we needed to do something different to ensure equitable access to all of our patients. We know that COVID taught us that we still have healthcare deserts. We saw the recent, I guess it's now a couple months old, article that shows that 47% of our counties don't even have a cardiologist. So we're going to stick to cardiology. Primary care is in more dire straits than we are. So this is what they put out. They also said, and this is a critical statement, especially for Virginia, go back to your 36% of Medicare Advantage. What they said was by 2030, all Medicare beneficiaries will be in a quality and total cost of care risk-based arrangement by 2030. That's only 5 years away. 6, I guess we can count 2025 as just starting. So 5 full years away. Many people that understand the Medicare product will never, yours truly included, go to a Medicare Advantage unless I'm forced to. And how am I going to be forced to? Because the people that we elect do not want to irritate the people who elect them. So how is that going to change? What are we going to see with this new Congress? Because remember, this will be a 4-year term. So that's going to get us pretty close to 2030. And we'll talk about some of our leaders that will be coming in. Also, when you really, really look at the data, when you really look at all these value-based programs that we have been putting into place, and I'm not sure, I know this is around being listened to across Virginia, so I'm not sure how many of you are in the BPCI, which was a bundle payment. There's been lots of different payment models that have been tried over the last 5 or 6 years, but one of them that was pretty popular, we joined it, and we made a fair amount of money on BPCI. We now know that it's on cost to cost Medicare $2 billion. So where is the logic in this? If traditional Medicare is cheaper, why are we pushing people into Medicare Advantage? So what is value? What is it really? So we've just heard that BPCI is going to be on pace to cost more than Medicare. Medicare versus Medicare Advantage and hierarchical coding. Those of you that have been to the summit know that if you gave me 3 hours of your day, I would delve into hierarchical coding. I'm going to leave you with just this one thought. Every provider on this call, every physician, every advanced practice nurse, every PA, anybody that's providing care to patients, I'd like you to do 2 things for me in 2025. Number 1, make sure that you list every single diagnosis that your patient has. Make sure that their risk is well documented. Number 2, make sure that you are extremely specific in every diagnosis. My physicians know that if I see unspecified chest pain in their list of diagnoses, it'll drive me to drink, and that's not coffee. So be careful. But here's the issue. Medicare realized 2 years ago, actually they realized it a long time ago, that hierarchical codes cost them more. The reason Medicare Advantage costs so much more is they realized that they get paid better if they can declare the patient sick. Lots of risk factors. That's why those of you who are administrators on the phone, remember the chart calls that United and Blue Cross were going to look at 1,000 charts, 2,000 charts. That was so they could go through your charts, make sure they listed all the diagnoses that you were treating the patient for, all the specificity, and they get paid a whole lot more than traditional Medicare. So they've changed it. Again, everything that we do, there's a reaction. So they are changing the hierarchical codes. In 2024 alone, it was projected that they were going to save $11 billion, and they're probably going to do it. Lots more we could say about that, but not this morning. So here's the key factor. Medicare Advantage are costing Medicare $321 higher per person than if they had been in traditional Medicare. Multiply that by the millions of Medicare. As we said, you've got about 1.6 million beneficiaries in Virginia, adds up to a lot of money. So that $7 billion, they now think is around $15 billion. So there's some thought process here about why we're doing this. Okay, what else is going on? Well, for the first time, starting a week ago, 9 days ago, we have a bundle. We have a bundle in Medicare. I did go through, Virginia's a little bit interesting. You're sort of a tiny state, so some of your hospital systems extend, so it was a little bit difficult to find all of the Virginia ones. I do have the list if anybody's interested. If your hospital obviously should know by now if you're in the team bundle, but I did want to make sure that you realize that we're in a bundle payment. There were 4 different disease processes that Medicare put in for 2025. Cabbage is ours. So, and those are some of the hospitals on the left that are in the bundle this year. And of course, it will be very, very interesting to follow this as we go through. So this is what our value is really talking about. So now we're going to number 2, which is site neutrality. Site neutrality in the academic world, I am sure now, because I've talked to so many of my academic colleagues, didn't really understand payment processes. I've just put across the top here the 4 different sites of service where you provide care that we do. Inpatient's easy. The big difference, and office was easy. The big difference are those 2 middle ones. The 2 middle ones that talk about our HOPDs. Why is that important? Because those of us that got employed in 2010, 2011, what we did was we stayed in our offices with our big imaging centers. I have 2 very, very large imaging centers. We stayed in our offices. We entered a transaction that sold our assets and our practice. And the difference between Sunday and Monday is I could then charge significantly more just because I billed on a different fee schedule. I was billing on the outpatient fee schedule. That's what site neutrality is all about. And because of COVID, when we shifted between inpatient and outpatient, we flipped completely. And now we're sitting at about an 80-20 outpatient versus inpatient. That dramatically impacted our hospitals, and we'll talk about that in just a second. So again, if you leave with no other knowledge besides documenting a little bit better, site neutrality is important. I also found when I talked about site neutrality that most physicians' eyes would glaze over. So try not to glaze over. But what I wanted to show you, if my mouse will work, is every single thing that we do, every single CPT code that you bill is comprised of this formula. You only see your RVU. You know that when you're reading an EKG, you get paid 0.17 RVUs. It's just something that is a must do. When you're doing an echo, this is for an echo. So we look at our Gypsy, which is your location. Virginia is not considered an expensive location. Don't tell your household budget that. Your malpractice is a lot better than Chicago, but this is why you get paid differently for doing an echo in different parts of the country, is because of this. The conversion factor is that thing that we were trying to prevent from happening. So this is how your payment for 5.89 RVUs for an echo is actually calculated. How does that come out to payment? So remember, you're going to get paid about $204 for an echo. The Medicare will pay 80% of that. Now remember, private payers, and we'll talk about them in a second, private payers pay totally different. So this is just your Medicare population. And then there's been the sequestration for a number of years. So in addition to that conversion factor hit, you also have the sequestration hit. So that cash in hand from that echo actually is only $160. Pretty significant difference. Now, where are you going to get the rest of that money from? Well, you hope you're going to get it from your patient. Medicare is a little bit better than our private insurers because most patients will carry Medigap insurance or that Part B, Part A insurance that is out of pocket from the Blues United, and that's why Medicare Advantage can happen. So you can see in 2024, so again, between New Year's Eve and New Year's Day, we lost about $6 per echo because of that conversion factor. We went from $201 down to $195. 2025, you can see the same thing. If you really want to look at these slides side by side, you can see how the practice expense went down last I checked. I don't think UVA or VCU or anyone else actually went down, Inova. I don't think your cost went down at all, but you'll see your practice expenses did all change. So now you can see in 2025, again, another, in quotes, slight decrease. Well, let's just take a look and depress ourselves for a little bit this morning. I call it this historical impact of tiny cuts. So if I go back to 2019 and I see I was paid $459 technically for an office echo, I'm now down to, as you can see in 2017, $243. You also can see the pro fee. You can see you're reading echoes much more for a lot less income than you did back in 1999. Why? I put that summary on the bottom, and this is why it's important, again, not to totally grasp all of these elements, but to understand that when these fee schedules come out, when these kids in Washington continue and in Baltimore with Medicare continue to make decisions, this is what happens. So the first thing that hit us was what we call the Deficit Reduction Act in 2009. You can see that big drop from $474 down to $290 with the DRA. That was a stroke in a December bill in 2008 that started this march towards impacting the office fee schedule. And it said that you could not pay any more in the office than the hospital. So that's why as the hospital went up, the office never went up. And then 2010, as I call it, the beginning of the end, that was the dramatic fee schedule hit. And you can see on the grid, it's almost a 50% cut from 1999. And you can just see things march through. I just put on there 2018, 19, 21, 22, and you can just see every year $4 or $5, $4 or $5, but it all adds up. So that's this issue with site neutrality. Why do we care? Well, we care because there is one more thing I just want to mention, so it's in the back of your brain somewhere. There was a bill that was passed in 2015 that said anything that's off campus. So those of you that now have hospitals that are not on your academic campus or are away from your main campus by more than 250 yards, they were grandfathered in. Meaning if you ever pull your imaging out of those sites, you would never be able to put them back in. Also means that you cannot build new sites off campus and charge that higher rate. So that was the first shot in 2015 to try to get this payment methodology figured out. Because as you can see, we spent over $944 billion just because of that difference in the fee schedules. So 2023, what happened? 2023 seems like forever ago, but there was all of a sudden a big flurry in Washington about maybe we were going to go to site neutrality. Maybe there would be legislation in the House that would start to equalize these payments across. Of course, the American Hospital Association, very powerful lobby, had a heart attack, literally, and it backed off. This is just some of the articles that came out, and we continue to see some noise in early 2024. And then it just sort of got quiet. But you will see a lot of press about these billions of dollars of facility fees that they talk about. Then we had another shot across the bow. This shot across the bow happened in November, and it was a Senate bill that appeared on November 4th, 2024, and it was a senatorial plan to implement site neutral payments, a pretty big shot across the bow. And why do we care? Here's why we care. I just took a couple of samplings of different things that you do every day. Nuclear stress, if I do it in my office, it's about $370. If I do it under the outpatient fee schedule, it's $1,300. So I'll just have you take a look at that. Stress echo is obviously a massive change, 121 versus 533. So this is at the core, at the infrastructure of why these finances are so unique and why so many cardiologists, about 80% are employed, was because of this specific element. So will our new Congress push for site neutral? I don't know. But one of the big things that we're watching closely as administrators is it eliminates the grandfathering. That would be very, very large. If they eliminate our grandfather status for all of these off-campus imaging centers, it's a direct connection to physician compensation. So that's why it's so important to continue to look at this as we kind of walk through. Let me just check to see if we've got any questions in the chat. So don't hesitate to put questions in the chat at any point. I usually say interrupt me, but that's a little bit hard as we're doing this. So here's the stuff from Politico. Of course, the American Hospital Association, same thing came out. We can't do this. The hospitals have a different cost structure. We provide a lot of services for free. Lots of angst on it, but I did want to make sure we talked about it. Then one other thing happened, and this happened early December. No, it didn't. It happened late, right after Thanksgiving, New York. So I can't wait to do this talk in New York, which I'm doing in a couple of weeks. New York put out a state notification that they were going to go to site neutrality. Now, how will that happen? Are they going to do it through their insurance commissioners? Are they going to go through what we call their Medicare advisory committees or their MACs? Because every single state has a different methodology of getting paid for Medicare. Again, your heads would spin if I told you how messed up it all really is. But interesting to note that this is also happening at the state level. So don't keep your heads in the sand. Make sure that you sort of listen to this again. This isn't about how to do a TAVI. This isn't about how to read the best MRI of the day. This is about the non-clinical part of your world. We all know that Robert Kennedy is most probably coming in as our Health and Human Service. We know Dr. Oz is going to run CMS. We knew that telehealth and site neutrality and redoing the entire CPT process was on the table. Luckily, in the omnibus bill right before Christmas, telehealth did come back, but just shortly. Changing telehealth would be a very difficult thing for us. So we do need to watch what's going to happen. Just want to mention a little bit, RFK Jr. has been talking a lot about changing all of the CPT component. He's going to try to wrestle coding from the AMA. AMA is who does coding. It's also important to remember physicians, believe it or not, are in charge of this process. It's called the RUC process. And physicians are the ones that meet several times a year under the AMA umbrella. But I'm not sure that we want to give up that piece. As broken as it is, physicians need to be driving this. So I just leave you with that thought as we go through this. So advocacy continues to be very, very important. I know most of the time physicians' eyes will glaze over when I talk about advocacy. Advocacy is what helped us win telehealth, and we actually won the conversion factor until Elon Musk got onto Twitter. And all that changed within about 48 hours when that entire bill was trashed and the new bill was put together. So this is our Physician Stabilization Act that we're still working on through the college. If you know your Congress, which I hope most of you do, I hope you watch the alerts from ACC or from any of your professional societies, and you really pay attention to this fee schedule, because we've got to get this issue fixed with budget neutrality. So it's very, very important to be involved in advocacy. So these are just the bills that ended up being agreed to until I mentioned Elon Musk entered the scene and started to convince people to kill the bill. We had the votes, and then they killed the bill pretty quickly. So it'll be interesting to watch the two of them manage Congress and look at where we're going to head. So number 3, so I know I spent a fair amount of time on the first 2 or 3. We'll now go through the rest, and you'll see why what we do on a day-to-day basis are really important. Our hospitals are in trouble for the most part. I've met a few that are doing very well. Their payer contracts with the third-party payers are better, and so they may not be having quite so much trouble. But post-COVID, margins for the hospitals continue to decrease. Why is that important for cardiologists? Because in most hospitals, and I would say all hospitals, but there may be someone out there that would prove me wrong, most hospitals rely on cardiovascular services for their contribution margin, the things that they can actually make money on to survive, both in access to care as well as some services that don't pay very much. So having those compressed hospital margins is difficult. And that compression has come, as we just talked about, that infrastructure that I just laid out for you is due to this change in payment models. And instead of a DRG payment, you get an APC payment. So this is just a little graph of what's happened. You'll see some of the hospitals are slowly coming out of it. They had to do a lot of human resource things with salary and compensation post-COVID. We had the quiet resignation. We had lots of issues with workforce that we'll talk about in a second. So these are the contributing factors, the contribution margins, how much money is left after payments and expenses, the operating margin, what it really costs them to operate the hospital. And we talked about the shift to outpatient. Cabbage and TAVR are about the only things left on what's called the inpatient only rule, meaning that you can only do TAVRs and cabbages under a DRG. There's no APC for them. A lot of us are discharging TAVRs same day or next day. So we have to watch all that because that could now give us another payment model as soon as Medicare realizes that our patients are not staying 2 or 3 days post-TAVR. Lots of complexities. I find it fascinating. Hopefully you at least can understand it. I put this as one of the objectives for our fellows because I really wanted to highlight and identify physician alignment because that world is changing too. It changed very fast in 2010 when we went from independent practices and academic practices into employed practices. So these are sort of the 6 areas that are open to our physicians. I think we need to train our fellows a little bit better or a lot better in our non-clinical competencies. I know Mike Valentine does a lot of work down at UVA with the fellows. And this is why, because when you're so engrossed in achieving your clinical competencies, you're involved in your specific subspecialty in cardiovascular, and then all of a sudden July is coming and you're like, oh my goodness, I need a job. I can't stay here forever. So these are the areas, obviously academia, independent, employed, private equity is coming up very quickly, multi-state MSOs. And yes, we have unionization even among some of our cardiologists. These are just some Metaxium slides that we use. As you can see, 88%. 24's data should be the same. I think we're holding right around 88%, although we are seeing some of our employed physicians moving over into private equity and or independence. Just a few things I put up here that we'll go through very quickly because sometimes people like to take a look at them and compare, what's my patient panel, how many new patients am I seeing? So this is just an example of looking at total new patients in a patient panel. What's a patient panel? A patient panel is something we look at in Chicago. This is the national average of 1,800 unique patients. Chicago, we only sit about 1,400 patients per cardiologist. You calculate that by looking at the number of patients you see within a 2-year time period one time. So we know our patients come back routinely, but we count our unique patients just once. So this is just an example of a patient panel. Looking at our new and return, we're starting to see this drop. Why? Because we don't have enough physicians and APPs. We're starting to see our return visits not stay on par because we just can't get them in. There are so many places right now that are having access issues. We used to pride ourselves that we would see anybody who was new, we'd see within 48 hours. We're now at 3 weeks. Sometimes my first available is out a couple of months. So access is becoming a huge issue. I put the compensation slide up there just because I know everybody likes to see what it's looking like between private and integrated. You'll notice 2021, it was pretty close. It started to take a little bit more of a delta as we go out. Looking at RVUs and subspecialty, advanced heart failure obviously is one of those areas that we continue to struggle with just because of the complexity of it. But just an example of what the Metaxium data is looking at as it relates to productivity components. Did I put compensation on per work RVU? Again, just something that lots of times people don't have access to it. I like to make sure this data is out there. It's available to everybody. Just checking the chat, make sure we're doing okay. Fitz, okay, Fitz, y'all listening? I see David's paying attention. So one of the things that we are seeing change is the increase of hiring our new fellows. It's been a dramatic change. But here's my cautionary tale to my fellows. Don't let the dollar signs sway you. Make sure you understand the governance, the culture. Can you be mentored? Will you be helped? How is the structure? How are they governed? Who controls the workflow? Who controls your schedule? We could talk for days to the fellows on how to make sure you're reading your contracts correctly, how you pick a practice setting. All of that's important. But I did think this was very interesting that in 10 years, the difference that we've seen in this whole area. So important, also important that your raises won't be as significant. It goes up much slower. So you come in a little higher, but it is going up much slower. Private equity. Not a lot of time for private equity. We've got a few more things we want to get through, but really important. Cardiology is sort of new on the block with private equity. Our goal is to educate as relates to private equity. You can see, and as the fellows are interviewing, make sure you understand what private equity is. If you're joining a company, make sure you understand what the scrape looks like. Make sure you understand what your equity position looks like. But as you can see, 38 groups in the South. Midwest, we're a little bit slower, but we've got a couple of physicians that I know very well that are in private equity. So we did want to chat about it. People always ask me who. So again, if you're interviewing with any of these individuals, this is the list as of, I don't know how far I got. Yeah, probably spring. So I'm hoping to get there were a couple acquisitions in the summer and the fall of 24. So there are a couple more since this slide was done. Unions, it's a reality. As physicians became employees as opposed to owners and shareholders, they fall under all the rules for unions. So now almost 75% of all physicians, not just cardiologists, are considered employees. That's why unionization is happening. We've seen Allina, we've seen Northwestern in Chicago, so we are seeing unions evolve. Multi-state MSOs, spent about 2 minutes on this. It's what I personally think is one of the lights at the end of the tunnel. It is a methodology where physicians can leave employment and turn that non-clinical element over to a medical staff office or a service organization that can do your revenue cycle, that can do your billing, your coding, your receipts, can help you with all the EMR types of things, all the HR benefits, all those types of things. There's 2 of them in the country right now. They're going to cross states. They've got a couple hundred physicians in them. We'll see. I don't know. We just have to keep our eyes open and look at the different business models for how we're going to deliver CV care. Number 5, we're going to do 5 through 10 pretty quickly because now we've set the stage for why we have the issue. Want to make sure we leave plenty of time for questions in the chat, which, by the way, hopefully everybody's having their cup of coffee, but no questions in the chat yet. John Rumsfeld did this picture. It's a perfect picture. I use it a lot. I should have put a picture in the middle. During COVID, our waiting rooms were empty. We did from door to exam room. We got out of that again pretty quickly. We have to transform. We have to change how we're doing this. It just isn't getting any different. And we have to make sure that we have access. We've got to make sure that we have a coordinated methodology so that our expertise can get to our patients. We've got to look at our deserts. We have to look at preventative cardiology. Access is really, really important because we need care transformation. We've already talked about the workforce crisis, not just the physicians, but our nurses, our techs, our rad techs in the cath lab, our dietitians. 11,000 people a day are turning to Medicare. They're aging. We have an aging population. We have a declining life expectancy in the US. That's not good. Our burden of cardiovascular disease, ever since pre-COVID, where we were starting to see that curve bend, that burden of cardiovascular disease, death, mortality, morbidity continues to go up. Health equity, we know we're not there yet. And we're still in a siloed delivery system. We're not going to talk about service lines. Service lines have taken hold in many hospitals, but not in all. In some hospitals, we still remain in our silos. So the bottom line is we have to redesign care. We have to redesign it, keeping that patient, understanding prevention. If we prevent disease, it'll be a whole lot better, but we just don't pay for prevention. It's a big issue. Where is AI going to fit in this? Where is innovation? Where is digital transformation? All these things we have to really do. We're talking about it, but we're just not doing it. How do we do it? That's my number 6, benefits of team-based care. Team-based care is our solution. It is so very, very important to produce or reduce burnout, to really share that. We need our teams led by our physicians. We need those plan of cares by our physicians. Once those guidelines are done by our professional society, when ACC releases guidelines, we've got to have our APPs coordinate these clinics that we'll talk about in a minute. Team-based care is the only way our physicians are going to survive. The burden of the Epic inbox has got to get solved. talk about that with AI. So team-based care is so important. We don't have time to talk about this MIPS and MVP. Some of you may not even remember MIPS. MIPS is embedded in the physician fee schedule. It has entered the back burner because it was so complicated, but it's still there. What's more important is it's going to go away. The penalty is becoming real. More and more practices are actually going to be penalized now. 26 will reflect 24 data, but we are going to be moving to these value pathways, and cardiology is a value pathway. So if you haven't heard from your quality team about this transition, because 25 really starts the first educational year for going into MVPs, if you've never seen the pathway for cardiology, you probably want to take a look at it. Team-based care is also across that continuum. It starts in the patient home, it ends in the patient home or in an extended care facility where that site of care is. We've got to get horizontally across our system, across our communities. We have to involve our community resources. It's the only way that we're going to do team-based care delivery. Subspecialty clinics have just been amazing to me. How we have subspecialized in cardiology over my experience in cardiology when I left hospitals in 99 and came to work with the physicians. It's been an amazing 25 years. We no longer have non-invasive. I have non-invasive who only want to do structural imaging. I have non-invasive that want to do a little bit of clinic and a little bit of imaging. We have all kinds, interventional, peripheral interventional, structural interventional, subspecialization. So having our subspecialty clinics, physician-led, APP run, so very, very important. These are just some of the more common ones that we use. So if you've not looked at subspecialty clinics, it is a way to start that transformation of care. It is really important. I'm just going to do 2 slides or 3 slides with Sam. Sam has traveled the globe with me during my vice president and presidential year because he's a great example in Virginia. If I'm in Roanoke and Sam develops shortness of breath, look at how many places he's going to enter my system. And no matter where he enters my system, we're going to treat him differently because we didn't have a full continuum of care. And he is totally confused. He has no idea what he's supposed to do. They discharged him, gave him all kinds of medicine. I'm sure they followed the 4 pillars of heart failure, but Sam's head is spinning. So we've got to get everything pulled up. We've got to get that care plan across the continuum, interdisciplinary, multidisciplinary, full team-based care. And we need an ambulatory procedure strategy. ASCs may be a black word to your CFO, but these sites of service are going to make a difference. So I wanted to make sure we at least identify in these environmental factors the growth of ambulatory centers with cardiovascular procedures. Of course, everybody was waiting to see if ablation was going to be approved for ASCs. It was not for 2025, but it's on the cusp. It's out there. We all know that we do lots of PV intervention. Obviously, we do CATs and intervention. So having a procedural strategy, those of you that are working on a strategic plan, critically important. 8, workforce issues. I don't have to tell you. 1 in 4 of our cardiologists are over the age of 61. They don't like to take call anymore. All kinds of stuff that we do with MedAxiom to ensure that we are working on workforce issues are also very, very important. Tom Maddox did a great task force looking at the supply and demand, looking at how the college can really help. As I mentioned, that hyperspecialization doesn't help our workforce because, again, as you subspecialize, your team needs to subspecialize. If I take my heart failure nurse and I put her in my structural clinic, she'll kill me. I mean, they develop their own subspecialization, which makes that pipeline so very, very important. That cardiology gap is not going to get better. Our pipeline, our fellows, we're not training enough of them, but yet look at this. We saw a couple of areas where we didn't even fill all of our matches this year. So it's very interesting. Nursing, not much different than cardiology. COVID impacted, that landscape continues to change for them as well. So just a few things that the college is doing. Ed Fry really did a great leadership page on the great resignation. So something to keep, and you guys all know this, you see it every single day. I had to put this in here. I only do this for my favorite people. I had to put it in here. because you'll see my physicians on the bottom. What are all these administrators doing? Present company excluded, I hope. We do need some good dyad leadership between our physicians and our administrators. But dear Lord, when I see 20,000 square feet of office space and I don't see a patient in there, why are we making the delivery of healthcare so complex? Why? Love every administrator, they're lovely people, but we have got to simplify this delivery of healthcare system. Number 9 is our social determinants of health. You've seen this slide, about 5 more minutes, and then I want to make sure. So those of you have to wake up. I need at least one question in there, otherwise I'll twiddle my thumbs. But that social determinant of health, what's the education? Where do our patients live? What's their support system? What's their income? Can they afford these drugs that we're ordering for them for heart failure? Where are they going to get these drugs? How is this happening? Where do they live? Do they live in a polluted area? So they're breathing bad air and climate. Do they smoke? Are they sedentary? Do they just sit in front of their computers? So as brilliant as you all are, as smart as we are, we're only going to be able to impact that patient outcome by 20%. All these other elements are critically important. And now even CMS has recognized that there's a code that when you assess that social determinants of health and you spend that time personalizing that plan of care for that patient, you will do fine. We'll go through this slide quickly because it really highlights to me that equality versus equity. Everybody's on the same stool, but the little kid still can't see. That's equally because they all have the same stool. Big kid says, hey, I'll give you my stool. Little kid can finally see. So now they're being treated equitably, maybe not equally because the big kid doesn't have a stool anymore. But why in the world don't we just take the boards down so everybody can see? Those systematic barriers, the walls, that's what we've got to look at. That's how we're going to address the inequality that we've got in healthcare. And we have to realize that we're like a glacier. We're going to be like the Titanic. We have all these patients that are sick now that we can't get in. But what's underneath that? What's underneath that iceberg? So many more patients getting sick, and yet our preventative component is just not there for the most part because we just can't pay for it. Diet, exercise, just getting everybody to know their blood pressure and their lipid. That would be a great start. How many people don't even know their blood pressure? And who provides that care? Also so important. I used to say our care teams have to look like our patients. I don't think that's true anymore, but they have to understand our patients. They have to understand the culture. You cannot preach to your culture. You have to teach patients to where they are. We must meet our patients where they are. So who provides that care is so very important. Health equity, the college has been doing a lot of work, a leader, actually, I would say, in health equity. So very, very important. And health equity is a culture. Your system has to live it. Your clinic has to live it. And it's a little bit difficult when we try to put health equity with our finances. How do we do that? How do we do that and stay sustainable, making sure we don't have to close our doors? Not so easy. So I like to put this slide in here because I do like to challenge everybody to advance health equity. And that starts at the top with leadership and governance. If you don't walk the walk, it's not going to happen. So don't just preach about it in meetings. Figure out how it works in your emergency room. Figure out how it works in your chest pain clinic. Figure out how we get patients into our clinics when we know we have such shortages. And use our data to help us advance that. Last but not least, AI. What can I say? Moving so fast, so critical to make sure that we keep this harnessed. Whether it's at the college level under Dr. Ami Bhatt, we have to understand how AI is entering our world. Some things it's going to help immensely. Number one, fix the Epic inbox. Whether it's through ambient learning, whether it's through some of our EMR stuff, but we've got to start to use the tools that we have. Use them for our pre-authorizations. We have to use AI to help us. We also have to make sure we're accelerating the dissemination of science. We need to make sure we're using this responsibly, ethically, and we need to continue to train and teach AI to our entire CV team, but more importantly, to our physicians who are leading our teams. We also have to understand that the complexity that we live in, it continues to grow. I'm old. I'm looking to see if I got some older colleagues with me on the phone. The pace of change is so amazing compared to when I first entered this field. The overload of information, the changing in the pharmacology, the changing of the technology is so quick. It is just absolutely amazing to me. In 1980, my lifetime, medical knowledge doubled every 7 years. In 2010, the doubling period was fewer than 75 days. 7 years to 75 days. Pre-COVID, those of you that were in med school, only 6% of what you know today was in your brain. It is so quick. There is so much at our fingertips. It is just an amazing time. And so we need to reframe it. We need to make sure that we know our human brain has got some limitations to it. So we need to provide cardiovascular care with the rigor that we've done in our clinical trials in our AI world. We can't be dependent on it, but we do need to embrace it. One of Ami's favorite slides, really looking at how we use it to optimize care, because we know many of our patients have got chronic management. We know we've got great tools that can treat them at home, remote patient monitoring, all kinds of things that we can use AI for. We also know that we have an incredible risk of failure to diagnose, so how we can identify that progression, what our EKGs can be telling us, how AI is learning that, how we use AI in our CT world, all those things. And then, of course, when do we need our physicians? When do we need that intervention? Machine learning isn't all it is. We need to make sure that we keep our physicians in the middle of AI and embracing AI. We need to embrace our point of care. Point of care ultrasound is just the tip of the iceberg with where we're doing. Our remote patient monitoring, so important. But then we get into the worried well. And we look at all that happens with that increasing of notification of our patients. How often do we want to get their data from their Apple Watch? Because remember, every time you get that data, you have to use that data. So be careful with that. Chat DOT, Chat GPT, all of those. I asked them how to build a perfect physician compensation model. Use it carefully. Use it, but use it carefully. It only knows what is floating around out there. That's not always accurate. So make sure we use it carefully. Virtual care telehealth is where we need, it's part of that transformation of care. Our wearables, obviously, all the remote patient monitoring, telehealth, but it all comes to our care team. Our care team is why they're so important and why we have to be joined at the hip. We have to be aligned in every single thing we do. So hopefully you're all still awake, enjoying your cup of coffee. Keep an open mind as it relates to innovation. Workforce flexibility, critical. We have people that don't want to come back to the offices. We have nurses that want to try to do things at home. Think about what we can do to have workforce flexibility. What do we do with our senior physicians as they want to wind down? How do we wind down call and keep things going? How do we distribute the workflow so we can maximize our team and not lose the most important intellectual capacity that we have? Dyad leadership, one of my key things, as I mentioned at the very beginning, an administrator and a physician working hand in hand, really complementing each other's skills in order to move an agenda forward. So very important. Solve our problems using best practices. It's so great that all of Virginia participates in education such as this. I hope you have found it useful. And then monitor the trends that we're heading at. Monitor those trends that we're looking at so we can all learn from each other. I happen to love this quote by Franz: "We'll meet the future not by dreams, but by action and indistinguishable enthusiasm." We've got to stay passionate. Don't let burnout get to us. I hope to see many of you in Chicago for our meeting in a few months. It's been an honor and a pleasure. I hope I even see more of you at our first gala that will be at the Field Museum. ACC is proud to partner with many of you, and I hope you do view it as your professional home. Just a reminder for your CME. And David, that sort of takes us to the end. Are there 1,000 questions in the chat box that I just haven't seen?
Yeah, thank you so much, Catherine, for such a great talk on a very complex topic that I believe, I feel like most physicians really have a poor understanding. But Yeah, we have come to the end of our presentation today by Catherine, and I have opened the forum for anybody who has a question or a comment for her
No,
before.
George always has a question, so I bet he's got at least one.
Yeah, I'm going to ask a sort of obtuse question, but it probably gets at a lot of things you said. I thought this was really great. Far faster than I could keep up. But
And I tried to go so slow.
right, for a friend of mine asked me recently, should I go into sign up for Medicare Advantage, or should I just continue on standard Medicare? And I said stay on standard Medicare because you got much more predictable management. But certainly that's not what's happening. So what should we advise people and advise ourselves?
So, so of course, this is being taped, but I will be perfectly honest. The reason and the way that Medicare Advantage, how United's and the Blue Cross and the Aetnas are getting patients is because they provide those services that Medicare doesn't. And for many patients, especially when we really look at our social determinants of health, those pharmacy charges, dental, vision, those things that you have when you're employed that you just sort of take for granted. And all of a sudden, when you retire, they're not there anymore. So Medicare Advantage, and that's what I tell patients. If you just can't afford, because good dental health, good eye health, we all know that, some of the sources of cardiovascular risk factors is there. So that's the advantage of Medicare Advantage. The disadvantage is your choices become very restricted. You get tied to pre-authorization. So when you really look at the pre-authorization process, Medicare Advantage accounts for a huge portion of that. So, and you have to be honest with patients that when I order a cardiac CT, or if you've got peripheral vascular disease, those types of things all have to be pre-authed. Your choice gets limited, your network gets limited, sometimes travel if you've got retirees that travel. So I think we explain it to them by being honest with them. There are benefits. Health clubs, some of them offer health clubs. As I mentioned, the dentist and vision tend to be the drivers for many patients. That's why they're going into them. Personally, but again, I'm very fortunate that I can, do vision and dental, but all patients aren't that way. So we have to understand, again, our care teams have to understand where our patients are coming from.
Thank you.
Cathie, I have a quick question. This is Greg Hunley. What do you see as the solutions moving forward to enhance the cardiovascular workforce?
Yeah, that's a really great question. And Tom did a great job in identifying the problem. The solutions aren't so easy, but we're starting to see some very creative solutions. MedAxiom has come up with some great solutions. So they have several academies. They have an academy for APPs. So we all know there's a lot of APPs coming out, but how long does it take us to get our APPs cardiovascular trained? MedAxiom has an academy that puts them through a cardiology specific. They've got an MA module. They've got a couple of different elements that help us in the practice setting. Techs, ultrasound techs, specifically vascular techs have always been a problem for us. Teaming up with our schools, offering our sites as their practicum location so that you can hire kind of the best of us. There's a practice that I know that worked with a junior college technology team, and they hired every single graduate. So it was just, how they did that. So I think aligning with the resources that we have out there. I think there's some things that are bigger than that, such as our pipeline, such as if you go back and look and see when our fellowship numbers, kind of where they were. And the other thing that I'll tell our fellows, I hope my academic people don't shoot me, but please keep yourself a little broad. We can't have 7 structural heart physicians in a group. We just don't need that many. I need peripheral vascular intervention. I need solid, STEMI coverage. We need clinic coverage. Even my general cardiologist, my non-invasives, I have some that just want to do structural imaging. That's all they want to do. The practice, the amount of new patients that we're seeing in our practice, that's critical. I see a question in here about our APP run team model. So it's honestly the only way I see subspecialty clinics working, because our at least in my world, our physicians are so busy. I need them in the labs. I need them in that diagnostic capacity, and then I need them to hand that treatment plan over to my APPs, and then I need my APPs to run my nurses, my dietitians, my pharmacists, my social workers that make up many of my subspecialty clinics, specifically heart failure, cardiometabolic, and the other one. There's a third one that are so important because they're so multidisciplinary. There's a whole, I do a whole talk on how to set up subspecialty clinics. Medaxium, if those of you that are members of Medaxium, Ginger has a number of phenomenal talks on subspecialty clinics that are APP run. Now that if I have a physician that wants to run the clinic, God bless them. But for the most part, I find that when our physicians are in clinics seeing new patients, they really need a safety valve clinic that can take those patients. Rule of thumb is usually we make sure our patients see our physician at least once a year, minimum of once a year. Some physicians, it's every other visit. So it all depends. But setting up your once you set up a subspecialty clinic the right way, you can replicate it. And whether you do it interdisciplinary, multidisciplinary is up to you. So for instance, our resistant hypertension clinic is nephrology and cardiology. Our pulmonary hypertension is pulmonary and cardiology. The academic centers tend to do those very well because you collaborate very well. In the community center, it was a little bit different. CardioOnc was probably the first one that started that way. And so I hope that helped. Otherwise, you see, I can go on forever. Sorry about that.
I think it's almost time, but I had one question for you. So for new cardiologists or new physicians who want to join like a private practice, in your experience in these practice management groups, what are the challenges that they mainly encounter, and how do you help them like overcome that as they transition into partnership?
So private practice is unique. And what I'm seeing is a lot of our younger physicians do not want the rigor that's required to run a private practice. That is a big generational change that I have seen. The physicians that started these practices with me, we eat, breathed, and slept growing our practice, not just clinically, but non-clinically. And that's why those multi-state MSOs, David, that's why I think that they are becoming more popular, because work-life balance, God bless you all, it is becoming much, and it should be, but that entrepreneurial spirit is so important. I say to you, if you're going to join a private, well, I'll say this to anything, it doesn't really matter what you're joining. You have to understand how it works. If they're in a private practice, they promise you partnership, promises are as good as rosebuds. If it's not in your contract, if it's not in writing, you don't have a guarantee. I think that's what you're asking. But choose wisely. Please choose wisely. Interview in all the different settings. You may not know what it is that you really want, but I'll tell you the number one thing, it's not money. It's governance. Who is governing your practice? Who is determining your workflow? Who is telling you that you have to be in the hospital here, in the office here, and back to doing this and this? Who is doing that? Is it the physicians or is it an administrator? It has to be. I feel very strongly. Physician workflow has to be driven by physicians, period. Do it in a dyad model, which is how we do it, but please, it has to be run by physicians, in my opinion.
Thank you.
I just really quick, I see one more question about whether or not ACC is partnering. Oh, go ahead.
Milo.
I think that was an accident. Sorry.
Okay. Yes, we in our innovation part of the college, which Amibot runs, we have a number of startup companies that we work with that is looking at workflow, whether it is ambient learning, such as Copilot and all the others that are starting to come out now, or whether it's point of care, whether it's defibrillators, community defibrillators. So there's a number of companies that the college does work with on their innovation side that we hope will work, help work. But as you can imagine, there's thousands of startup companies, and of those thousands, two will be successful. So it's a complicated field, but yes, the college is working with it. And I don't want to take us too far over time because I would sit here and talk with you all morning. So
Cathie, thank you. Thank you very, very much. This was great.
thank you so much. It's an honor. I hope your water comes back. I hope the snowstorm Saturday isn't nearly as brutal. Make a snowman. Enjoy the day. Thank you so very much. Hope to see you in Chicago.
Thank you.
Take care. Bye-bye.